Hello guys, welcome back to another video in this series of videos which is known as Anesthesia Foundation course, and today we are going to talk about opioids. Alright, so the term opioid is derived from juice of opium poppy plant. Derived from juice of opium poppy plant, which is Papaver somniferum. So what is the main role of opioids in anesthesia? It is for giving analgesia, pain relief. So write it down. The main role of opioids in anesthesia is analgesia. For analgesia. So let us classify opioids. Classification. The opioids can be classified into natural, semi-synthetic and synthetic. So natural, semi-synthetic and synthetic. So what are the examples of natural opioids? It is morphine and codeine. Then what are the examples of semi-synthetic opioids? Heroin is a semi-synthetic opioid. Alright, then comes the synthetic opioids, your artificial opioids. These opioids are fentanyl, your tramadol. Alright, rest all of the opioids, the alfentanyl, remifentanil, sufentanil, all these fentanyls are synthetic opioids. Got it? Now let us know about their receptors, opioid receptors. These drugs act on opioid receptors, which are nothing but G protein coupled receptors. The opioid receptors are G protein coupled receptors. So they are G protein coupled receptors. Alright, there are 4 types. 4 receptors are there. The mu receptors, then comes the delta receptors, then comes the kappa receptors. Then there is something called nociceptin receptors. Alright. Now for these receptors, there are again endogenous ligands. Got it? So the endogenous ligand for mu receptors is endorphins. Then for delta receptors, it is enkephalins. Then for kappa receptors, the endogenous ligand is, for kappa receptors, it is dynorphins. Then for the nociceptin receptors, it is orphanin. Alright. So mu receptors are the most significant receptors. Mu receptors are mainly useful for sedation and analgesia, mainly responsible for this sedation and analgesia properties of opioids. So mu receptors are the most important receptors. Now based on these receptor interaction with the drugs, again opioids are classified into 4 types or into 4 groups. Okay, so classification based on receptor interaction. They are classified into 4 groups. Alright. So the first group is pure agonist group. That is, they stimulate mu, kappa and delta receptors. Purely agonist type. So stimulate mu, kappa and delta receptors. So what are the examples? Examples are morphine, fentanyl. Alright, your pethidine, remifentanil. Alright, so all these are pure agonist receptors. Pure agonist group of drugs. Then comes partial agonist. The partial agonists are agonist at mu receptors, and they are antagonist at kappa receptors. Your example is buprenorphine. Clear? Then the next group of drugs is agonist-antagonist type. Agonist-antagonist type of drugs. So the example is pentazocine, nalbuphine, your butorphanol, butadol or butorphanol. Agonist-antagonist group of drugs are also known as mixed opioids. They are also known as mixed opioids. They are agonist at kappa receptors, and antagonist at mu receptors. Alright, then comes the fourth group, which is pure antagonist group. So they can be used as reversal agents for opioid toxicity or opioid overdose. The pure antagonist examples are naloxone and naltrexone. They block all the three receptors. They block mu, kappa and delta receptors. And the most commonly used receptors for analgesia are pure agonist type. So pure agonist type group of drugs are the most commonly used for analgesia. Clear? Now let us move forward. Let us learn about the first prototype drug, which is known as morphine. The morphine is the prototype drug for the mu agonist group of drugs. Clear? The effects of morphine are due to its action at the mu receptors. Okay, again the mu receptors can be mu1 receptors and mu2 receptors. Alright, and based on their action with the receptor, what does it provide? When they act on mu1 receptors, it provides analgesia at the level of supraspinal and spinal level. And when they act at mu2 receptors, they provide analgesia at the spinal level. When mu2 receptors are utilized, they provide euphoria. They develop euphoria. They have a low abuse potential. Meiosis is caused when it acts on the mu1 receptors. It also causes bradycardia, decrease in heart rate. Then it can cause hypothermia. Then there is urinary retention. Okay. So its actions on mu2 receptor. There is depression of ventilation. Okay. Then there is constipation. Then the physical dependence is also caused due to action on mu2 receptors. So physical dependence. Alright. So now let us move on with morphine. Now what are the routes of administration of morphine? Morphine can be given IV it can be given IM, it can be given through oral route, and it can also be given by a nebulizer by aerosol route. Clear? Then how it is metabolized? Metabolism, metabolized in liver and kidneys, metabolized and excreted by liver and kidneys. So what is the major metabolite of morphine? Major metabolite, it is morphine 3-glucuronide. Morphine 3-glucuronide. Clear? This is an inactive metabolite. And the minor metabolite is morphine 6-glucuronide. Morphine 6-glucuronide. This is an active metabolite. The minor metabolite is active. They both are produced in a ratio of 9:1. M6G is the active metabolite, and it can produce analgesia and respiratory depression. Alright. Now what is the elimination half-life of morphine? Elimination half-life 3 hours. It is 3 hours. Now let us know what are the effects of morphine on various organ systems, beginning with cardiovascular system. So what are its effects on organ system? Cardiovascular system. So morphine can cause bradycardia, that is decrease in heart rate. Alright, it causes decrease in systemic blood pressure. Clear? Then why are these effects occurring? It is probably due to release of histamine. Okay, it is probably due to histamine release. Okay. Then it does not cause direct myocardial depression. Doesn't cause direct myocardial depression. Alright. And it also does not sensitize heart to catecholamines. What happens if heart is sensitized to catecholamines? It can cause arrhythmias. Okay, so there is no arrhythmias with morphine. Clear? Now what are its effects on the respiratory system? Okay, there is a dose dependent respiratory depression or depression of ventilation because it is acting at the mu2 receptors. Okay, dose dependent respiratory depression. Okay, mu2 receptors. And if you give very high doses, it can cause apnea. Okay, which can lead to death. This is called as opioid overdose. Okay, so most common cause of death is opioid overdoses due to apnea, due to respiratory depression. Alright, then what happens to respiratory rate? There is a decrease in respiratory rate, and also there is an increase in tidal volume, which is due compensation to decreased respiratory rate. So compensatory increase in tidal volume. Then there is increase in airway resistance. probably due to bronchoconstriction, probably due to constriction caused by histamine release, drug-induced histamine release. So, histamine release causing airway resistance. Alright. Then there is decreased ciliary activity. Decreased ciliary activity. Then morphine will also depress cough centers. It depresses cough centers. Clear? Then what about central nervous system, CNS? There is a decrease in the cerebral blood flow. Decreases cerebral blood flow. Decreases the intracranial pressure. And decreases EEG activity. EEG activity. Clear? So in patients with head injury, there is an increase in ICP due to hypoventilation. There is an increase in ICP due to hypoventilation. Hypoventilation. Therefore, morphine should not be used in head injury patients. Therefore, it is contraindicated in head injury patients. Head injury patients. I hope it is clear. So let's move on. What are its effects on eye? Effect on eye causes miosis due to mu1 receptor action. Causes miosis. What is the nerve which is involved? It is oculomotor nerve, and the nucleus involved is Edinger-Westphal nucleus. So Edinger-Westphal nucleus of the oculomotor nerve. And then morphine can cause muscle rigidity. This usually occurs when large doses of morphine are given through intravenous route or IV route. Okay, IV morphine in large doses. This will cause chest wall rigidity. Which has a fancy term which is known as wooden chest syndrome. So you have to be very careful while giving morphine IV. Alright. Then how do you treat this wooden chest syndrome suddenly if it occurs intraoperatively? You can give opioid antagonist like naloxone or naltrexone. Clear? So the treatment is naloxone. And you can also give muscle relaxant. That is neuromuscular blocking agents. Alright. So what are the action of morphine on biliary tract? The morphine can cause biliary muscle spasm. Which can result in a biliary colic. Which will lead to epigastric pain. Patient can complain of epigastric pain. This pain can be relieved using naloxone. So the treatment is naloxone. See, if the epigastric pain is due to biliary colic, naloxone is enough for the treatment. If even after giving naloxone, if the pain is not relieved, then it can be due to MI also. So the treatment can be NTG, nitroglycerin. Your nitroglycerin can treat both biliary colic pain and epigastric pain due to myocardial infarction or angina MI. But naloxone can treat only the pain due to biliary colic, which is due to morphine. Alright. So moving on, what are its effect on the gastrointestinal system, GIT? You It can again cause spasm of the GI smooth muscles, It can also cause constipation. So when there is diarrhea, morphine can be given. Alright, so it can cause constipation. Then there is delayed gastric emptying. Alright. Now morphine can also cause nausea and vomiting. Nausea and vomiting is a side effect of morphine. Nausea and vomiting. Then why does it occur? It is due to direct stimulation of the CTZ, direct stimulation of the chemoreceptor trigger zone in the brain. So direct stimulation of CTZ. Where is it present? The floor of the fourth ventricle. At floor of fourth ventricle. Okay, and this can also be, or nausea and vomiting can also be due to direct dopamine receptor stimulation. Okay, dopamine receptor stimulation. Alright, now let us know what are the effects of morphine on the genitourinary system. Its effect on genitourinary system. Okay, now morphine will increase the tone and peristaltic activity of the ureter. Increases tone, increases peristaltic activity. Peristaltic activity of ureter. Clear? And it also increases the tone of the detrusor muscle. Increases detrusor muscle tone. This will cause urinary urgency. But here the problem is urinary sphincter tone is also increased. Urinary sphincter tone is also increased. So the person is having urinary urgency, but the sphincter tone is also increased, so the person is not able to void. There is urgency, but he is unable to void. That is the kind of situation with morphine. Okay, so there is difficulty in voiding. Alright, now moving on. What are the cutaneous changes that occur with morphine? Cutaneous changes. There is dilatation of the cutaneous blood vessels. Dilatation of cutaneous blood vessels. Where is this dilatation prominent? On the face, neck, upper chest. Face, neck, upper chest. This is again due to the histamine release. Okay. Now this will cause flushing and warmth over the face. Flushing and warmth. Alright. It can also cause erythema. It can also cause urticaria or itching. Especially at the injection site. Then there is also conjunctival erythema. There is conjunctival erythema. Pruritus. Alright. Now, what is its effect on the placental transfer? How does it affect the fetus and the placental barrier? So, placental transfer. Opioids readily transport across the placenta. Readily transport across placenta. So what happens? This will cause neonatal depression. Neonatal depression. Now, what are the hormonal changes? Hormonal effects of morphine. It will decrease plasma cortisol concentration. Plasma cortisol concentration. How? By influencing the HPA axis. By influencing the HPA axis. Influencing HPA axis. Clear? Now, what are the effects of morphine on provocation of coughing? Provocation of coughing. Or the cough reflex. This will occur especially due to three opioids, which are fentanyl and its congeners like sufentanil and alfentanil. This is also called as opioid-induced cough. Opioid-induced cough. Why does it occur? It is due to imbalance. Between the sympathetic and the vagal innervation. Imbalance between the sympathetic and the vagal innervations. Vagal innervation of airway. Alright. Morphine do not cause this provocation of coughing, but it is caused by fentanyl and its congeners. Remember, morphine does not cause this. Morphine do not cause this. Clear? Now let us talk a little bit about overdose of opioid. So what is the principal manifestation? Principal manifestation is depression of ventilation. Now, what is a triad of opioid overdose? There is a triad of opioid overdose, and the first one is depression of ventilation, and the second one is myotic pupils, which is followed by mydriasis. If there is severe hypoxemia. Why does mydriasis occur? Due to severe hypoxemia. Then the third one in the triad is coma. And the other effects are flaccid muscles. Then there can be pulmonary edema. Alright, then how will you treat opioid overdose? You can put the patient on the mechanical ventilator if there is respiratory depression or apnea. Mechanical ventilator. ICU support, mechanical ventilator. Then you can start the patient on opioid antagonists like naloxone. Clear? Now let us talk about other opioids. So what are the other important opioids? The first one is MAPREDIN. MAPREDIN, it is also known as pethidine. MAPREDIN or pethidine. Okay, it has features similar to lignocaine and atropine. Okay, it has features similar to lignocaine and atropine. Lignocaine and atropine. The potency of MAPREDIN is 1/10 of that of morphine. So 1/10 potency of morphine. Clear? And it is the only opioid which is considered adequate and can be given for surgery intrathecally. Okay, it is the opioid which is considered adequate for surgery. Adequate. That is why I told you it has features of lignocaine. Adequate for surgery when given intrathecally. This opioid itself is enough for when given intrathecally. Because it has effects on sodium channels also, it can cause sodium channel blockade. Can cause sodium channel blockade. That is local anesthetic like effect. Local anesthetic like effect. This can be your MCQ. Which of the following opioids can show local anesthetic like effect? Answer is MAPREDIN or pethidine. Alright. Now what is its use? The main use of MAPREDIN is for post-operative shivering. Drug of choice. Post-operative shivering. This was a previous year question. Post-operative shivering. Drug of choice is MAPREDIN or pethidine. Now what are the side effects caused by it? It has atropine-like effect. That is, it increases heart rate. It increases heart rate, which is nothing but atropine-like effect. We have seen morphine decreasing heart rate causing bradycardia and hypotension. Now here MAPREDIN we are seeing atropine-like effect, increase in heart rate. This is important. Clear? Then there is accumulation of its metabolite, which is norMAPREDIN. Accumulation of metabolite, which is norMAPREDIN. norMAPREDIN, which is a metabolite of MAPREDIN. Metabolite. And this can cause delirium and seizures. This can cause delirium, seizures, and sometimes myoclonus. Alright. Then what are the other side effects? It can also cause serotonin syndrome. What happens in serotonin syndrome? There is hypertension. There is increased heart rate, tachycardia. Then there is hyperthermia. Then there is diaphoresis. Then there is confusion. All these can occur due to MAPREDIN. So this occurs when MAPREDIN is given with MAO inhibitors, monoamine oxidase inhibitors. Okay. When it is given with MAO inhibitors or SSRIs. Example for SSRI is fluoxetine, selective serotonin reuptake inhibitors. And the patient can finally end up in hyperreflexia, ventilatory depression, and coma. The patient can finally end up in coma. This is called as Serotonin Syndrome. Alright. Now moving on, let us learn about the next drug, which is known as fentanyl. Many questions have been asked based on fentanyl in your previous year examinations. Fentanyl is a phenylpiperidine derivative. Phenylpiperidine derivative. The potency of fentanyl is very important. It is 125 times more potent than morphine. Fentanyl is 125 times more potent than morphine. It has a rapid onset of action. But it has a shorter duration of action. The rapid onset is due to high lipid solubility. And the short duration of action is again due to rapid redistribution. Alright, where does it redistribute to? To fat, lungs and muscles. Fat, muscles and lungs. Clear? Now where is fentanyl metabolized? It is metabolized in the liver. Metabolism in the liver. Now what is the metabolite? It is norfentanyl. Metabolized to liver to norfentanyl. What is the half-life or half-time? 3 to 6 hours. Now what are the major uses of fentanyl? It is used mainly for providing analgesia during anesthesia. In what routes this fentanyl can be given? This is a previous year question. Routes of administration of fentanyl. It can be given through IV route, IM route, oral route, intrathecal route. It can be given through transdermal route. And not intradermal route. Both are different. It can be given as transdermal patches, not intradermal route. Clear? Transdermal route. Then it can also be given transmucosal route. It can also be given through epidural route. Alright, so all these are routes of administration of fentanyl. It can be used to blunt hypertensive response, blunt intubation response. So it will blunt hypertension and tachycardia during intubation. Alright, it is a cardiovascularly stable drug. Okay, it can be used as a sole anesthetic agent also. In cardiac cases, it is used as a sole anesthetic agent and it can be given in 3 to 4 times higher doses. For cardiac patients, cardiac surgeries especially, sole anesthetic agent at higher doses, at large doses. Clear? Why it is CV stable? Because there is no histamine release with fentanyl. And there is no myocardial depression. There is no direct myocardial depression. Myocardial depression. And also there is decreased stress response to surgery. Now it can also be used intrathecally, subarachnoid block or spinal anesthesia. Intrathecally, around 25 micrograms dose. So it can be used for spinal anesthesia and labor analgesia. spinal anesthesia and labor analgesia. Labor epidural or labor analgesia. Clear? Then it can be used as transdermal patches. Transdermal skin patch. Where are these patches used? They are used for especially post-operative pain. After surgery, post-operative pain, and also for cancer pain. For cancer pain, the dose of around 75 to 100 microgram per hour. 75 to 100 microgram per hour. Then they are also available to be taken transmucosally, orally, like lollipops, transmucosal route, transmucosal or oral route. Transmucosally, you can chew the lozenges, available as lozenges. Then they are also available as lollipops for child, lollipops for children, at age of 2 to 8 years. Clear? Here the dose will be 5 to 20 microgram per kg. Alright, 5 to 20 microgram per kg. But the only disadvantage is it has a high incidence of nausea and vomiting through this route. High incidence of nausea and vomiting. Nausea and vomiting through this route. Clear? And the next drug is sufentanil. It is a fentanyl congener, sufentanil. This drug is 5 to 10 times potent than fentanyl. 5 to 10 times potent than fentanyl. Potent than fentanyl. And also there is an advantage that it causes less respiratory depression. Causes less respiratory depression or depression of ventilation, and also it can give prolonged analgesia. These are the advantages. Prolonged analgesia. 3 points about sufentanil. Enough. Now we have alfentanil. Alfentanil. This drug is less potent than fentanyl. Alfentanil is less potent. That is about 1/10 of the potency of fentanyl. 1/10 than fentanyl. And also it has a shorter duration of action than fentanyl. Short duration of action. Short duration of action than fentanyl. It has a rapid onset of action. Rapid onset of action than fentanyl and sufentanil. Than fentanyl and sufentanil. That is, it has a good rapid effect site equilibrium. Okay, it achieves effect site equilibrium very rapidly. That is why it has a rapid onset of action. Clear? Rapid effect site equilibrium. And also there is very less incidence of post-operative nausea and vomiting through alfentanil. Less incidence of post-operative nausea and vomiting. Alright. Then we'll note few points about remifentanil. Remifentanil. The potency of remifentanil is very similar to that of fentanyl. So it has a potency similar to fentanyl. And the most important point about remifentanil, which can be asked in the exam, is its structure. The structure of remifentanil is different from that of all other opioids. So structure of remifentanil. It has a ester linkage. Okay. It has a ester linkage. Whenever there is an ester linkage, again the metabolism will be quite different from the other opioids or other drugs. So there is an ester linkage. This is very important. So it is metabolized. It is metabolized by hydrolysis, by esterases, by specific enzymes which are known as esterases. Metabolized by plasma and tissue, non-specific esterases, by a process known as hydrolysis. Now what are the advantages? It has a brief action, short duration of action, or you can say it has a shortest acting opioid. This question was previously asked. Shortest acting opioid. So very short acting or brief action. For both the questions, the answer is remifentanil. And also there is a rapid onset and offset. Short acting, rapid onset and rapid offset or recovery. Then this drug is easily titratable. And there is no accumulation of metabolites. Alright, I hope this is clear till now. Now one thing you have to remember about remifentanil is you have to avoid administering this drug intrathecally. Okay? Avoid spinal or epidural administration. Why you have to avoid? Because it has a preservative which is known as glycine. Due to preservative which is called as glycine. This glycine is a neurotransmitter which is inhibitory. So this is an inhibitory neurotransmitter. So that is why we avoid remifentanil through intrathecal or epidural routes. Inhibitory neurotransmitter. Alright. Now what are the uses? It can be used for these opioids or fentanyl and its congeners. They can be used for analgesia, primarily analgesia. They can be used for labor analgesia. Clear? Then they can be used for total intravenous anesthesia or TIVA or total intravenous anesthesia. Clear? Then the remifentanil can also be used for daycare surgery because it is short acting, short duration of action. So it is preferred drug for daycare surgery. Opioid of choice, daycare surgery. And it is also preferred for renal disease patients because the metabolism and excretion are not dependent upon the kidney. So it can be used for renal disease patients. Drug of choice again, renal disease patients, opioid of choice. It's remifentanil. Alright. Now let us know the disadvantages also. It can cause acute opioid tolerance. and it can also cause hyperalgesia, which can be treated through ketamine. Treatment is ketamine. Alright, that is about remifentanil. Now we will learn about the most commonly used opioid, which is tramadol. It has an affinity for mu receptors. And it also has a weak affinity for kappa and delta receptors also. Weak affinity for kappa and delta receptors. Alright. Then it is 5 to 10 times less potent than morphine. Morphine itself is less potent than fentanyl. And tramadol is 5 to 10 times less potent than morphine. Less potent than morphine. Alright. Then it inhibits the neuronal reuptake of serotonin. Inhibits reuptake of serotonin. And norepinephrine. Serotonin and norepinephrine. Now, what are the uses of tramadol? Obviously, it can be used for analgesia. Tramadol is also a preferred drug for shivering, perioperative shivering. Again, the mechanism of action of shivering is also the inhibition of the neurotransmitter serotonin and norepinephrine release. Alright. Now it can also be used for chronic pain conditions. Now, what is the advantage of tramadol? It causes less respiratory depression and there is less abuse potential than compared to other opioids. Less respiratory depression and less abuse potential. Alright, now what are the adverse effects? It can cause nausea and vomiting. Then there is interaction with coumadin anticoagulants, interaction with warfarin group of drugs, coumadin anticoagulants. Then it can cause seizures. So better avoid it in patients with epilepsy. Avoid in epilepsy patients. It can also cause hypotension and bradycardia. And these two conditions occur especially at the high doses of tramadol. Clear? Now let us know few points about pentazocine. It is also known as Fortwin. It is usually given in combination with phenyramine, Fortwin Phenargan. Okay, so pentazocine is a benzomorphan derivative. It is given as 10 to 30 mg IV. It is used as an analgesic for moderate pain. The most common side effect being sedation. Most common side effect for pentazocine is sedation. It It can also cause diaphoresis, and it can cause dizziness. Enough. That is about pentazocine. Let us know few points about butorphanol. The most important thing is its side effects. Butorphanol can again cause sedation. Clear? It can cause nausea and vomiting. It can again cause diaphoresis. Like all other opioids, it can cause ventilatory depression, which is profoundly seen sometimes with the butorphanol. Ventilatory depression. It can be given 2 to 3 mg IM. For analgesia. Clear? This 2 to 3 mg is similar to 10 mg of morphine. The potency is similar to 10 mg of morphine. 10 mg of morphine. Then we have buprenorphine. This is another opioid. Buprenorphine. Now this drug is derived from thebaine. Okay, it can be given as 0.3 mg IM. This 0.3 mg IM dose is similar to 10 mg of morphine. In potency, it is similar to 10 mg of morphine. 10 mg of morphine. Now moving on, what is the onset? The onset is 30 minutes for buprenorphine, 30 minutes. And its duration of action is very long. It is 8 hours. 8 hours duration of action. Then it can be used for spinal or epidural administration also. Buprenorphine is used as an adjuvant for spinal anesthesia as well as epidural anesthesia. Used for spinal or epidural administration. Now it has a side effect which is drowsiness. Drowsiness is the side effect. Drowsiness. It can cause nausea and vomiting. And it can also cause dose-dependent respiratory depression in ventilation or respiratory depression. Side effect is depression in ventilation. Alright, I hope this is clear. Now let us talk about opioid antagonists. Opioid antagonist drugs. We have already seen naloxone and naltrexone. So naloxone, it is an opioid antagonist and has a short duration of action. About 30 to 45 minutes. 30 to 45 minutes action. It reverses the opioid-induced analgesia and respiratory depression. Reverses analgesia and ventilatory depression. These effects of opioids can be reversed. Ventilatory depression. What is the dose? It is about 1 to 4 microgram per kg IV. 1 to 4 microgram per kg IV. Clear? Now what are the side effects? This can also cause nausea, vomiting, then sympathetic stimulation, hypertension and increased heart rate. Clear? It can also cause dysarrhythmias. Because when you give naloxone, the pain response is again elicited and this will cause sympathetic stimulation and the person will develop hypertension and tachycardia. Sudden relief of pain. Okay. Sudden reversal of pain relief. Again the person will start percepting pain and he will develop hypertension, tachycardia, and he can also develop dysarrhythmias and he can land up in VF also, ventricular fibrillation. Okay, he can also land up in VF. Sometimes it can also causes pulmonary edema. pulmonary edema. Okay, write down here sudden reversal of analgesia, sudden reversal of analgesia leading to pain, which will cause these effects, Then we have naltrexone. This is long acting, unlike naloxone. This is long acting, acts for more than 24 hours effect. It can also treat alcoholism. And this is also effective orally effective drug, Then we have a newer opioid reversal agent. There is one newer agent which is albumopan. It is a novel peripheral opioid antagonist. Clear? Now we'll know one point about patient controlled analgesia. There is something called as patient controlled analgesia, where patient will be able to deliver his own analgesic or own dose of opioid by just clicking a button. Okay, that is patient controlled analgesia or PCA. Okay, there is an electric pump. There is a programmable electrical pump. Now this pump will deliver a prescribed dose of drug. The doctor will fix the dose of drug, and whenever the patient feels pain at a regular interval, when he presses the button, the machine will deliver the specified dose of drug to the patient, the specified dose of opioid. Okay, programmed electrical pump which delivers a prescribed dose of drug. On patient's demand. I hope this is clear. Now lastly, let us learn a few points about neuraxial opioids. Now opioids can be used for spinal and epidural analgesia. So where does these drugs act? They act at the substantia gelatinosa, which is present at the dorsal horn of the spinal cord. Now here the most important MCQ is the side effect of the neuraxial opioids. Important side effects. This is a previous year question. Pruritus. This is the most important side effect. Pruritus again occurs at face, neck and upper chest. Okay, pruritus. Then it can cause urinary retention. Then this it can also cause ventilatory depression. Then what are the other side effects? Nausea, vomiting, then sedation, sometimes CNS excitation. Clear? It can also cause reactivation of the herpes simplex. Virus. Herpes simplex. Especially after administration of morphine epidurally. Epidural morphine. Clear? Sometimes it can also cause priapism, that is sustained erection in males, sustained erection of penis in males. This can also occur after neuroaxial opioids. Now, what are the advantages of opioids over local anesthetic for neuroaxial techniques? Advantages of opioid over LA. Okay, there is no motor blockade. We can give the patient opioids and patient will have a good sensory pain relief. Okay, no motor blockade unlike local anesthetic. And also there is no sympathetic blockade. And also it is cardiovascular stable. There is no hemodynamic imbalance. Okay. Then the pain relief is also better than local anesthetics. Better pain relief. There is no skeletal muscle weakness. There is no residual skeletal muscle weakness with opioids. Clear? And also there is no loss of proprioception. No motor blockade, no proprioception loss. Alright. Now what about epidural administration of drugs? Epidural administration. There is a difference for morphine and fentanyl because the lipophilicity is also different for both the drugs. So for morphine, which is a hydrophilic drug, so it has a slow onset and a longer duration. And it is also less absorbed through IV route. Morphine. On the other side, there is fentanyl and the congeners of fentanyl. All these drugs are lipophilic drugs. They are lipophilic drugs. These drugs, majority are absorbed intravascularly. Majority of drug absorbed IV. Okay. So that is about epidural administration of morphine and fentanyl. And the last thing we are going to cover in this topic is TIVA. Let us know a few points about total intravenous anesthesia. TIVA or total intravenous anesthesia. What do you mean by total intravenous? Here we are not going to use any inhalational agents. So no inhalational agents or volatile agents. You are not going to use your halothane, isoflurane, sevoflurane. No volatile agents. And no use of nitrous oxide. But still you can use oxygen. Oxygen can be used. Nitrous oxide should not be used. In the TIVA, we are going to give opioids. Plus another drug which has a potential of producing hypnosis and amnesia. We have already seen such kind of drugs. The example is propofol, which is the most commonly used. We give fentanyl plus propofol. This is the most commonly used combination for total intravenous anesthesia. So what does fentanyl give? It can give analgesia. It will provide analgesia. It will maintain hemodynamic stability. Now it will also blunt the response to noxious stimuli. blunt noxious stimuli response. So it will prevent hypertension, tachycardia, arrhythmias. Okay, blunt response to noxious stimuli. Alright, now propofol has the advantages of hypnosis. It will produce hypnosis, amnesia. Propofol also has anti-emetic action. It also has anti-emetic action. Anti-emetic action. Clear? So how do you give TIVA? How do you give TIVA? You give a bolus dose of those drugs, fentanyl and propofol, bolus dose of drugs. This is known as induction. This is known as induction. Then you put an infusion. Then you put an infusion of these drugs. The infusion is IV through pumps, through specialized pumps. This is known as maintenance dose. This is known as maintenance dose. And these pumps are known as TCI pumps or target controlled infusion pumps. Target controlled infusion pumps. Target controlled infusion pumps. Now what are the major indications for TIVA? Major indications. Why you are not using inhaled anesthetics? Patients who are susceptible for malignant hyperthermia, you can give TIVA. So for malignant hyperthermia susceptible patients, you already know volatile agents and succinyl choline can cause malignant hyperthermia. In susceptible patients, you can give TIVA, total intravenous anesthesia. Then in patients who have a history of severe nausea, vomiting in the past, previous history of severe post-operative nausea, vomiting, you can give TIVA. Then for neurosurgery, you want to prevent the rise in intracranial pressure. To limit the rise in intracranial pressure, you can use TIVA for neurosurgery. Alright, then you can use it in the patients with myasthenia gravis. Here you want to avoid the neuromuscular blocking drugs. To avoid neuromuscular blocking drugs. Clear? Here you want to avoid volatile agents. Volatile agents for maintenance. Then it can be used for daycare surgeries. TIVA can be used for daycare surgeries. It is also indicated for long QT syndrome, patients with long QT syndrome. That is more than or equal to 500 milliseconds. Corrected QT. Alright, in all these patients, total intravenous anesthesia is very much indicated. Now, are there any disadvantages for this TIVA? Yes, we are giving the drugs through machine. So sometimes if there is any technical error, it can cause overdosing or underdosing of the drugs. Okay, overdosing has its own complications. And if there is underdosing, then again the depth of anesthesia is not maintained. Patient will have pain. There is no proper analgesia or hypnosis. Alright. There is awareness during anesthesia. So there is increased incidence of awareness. Awareness if underdosing of the drugs occur. Underdosing of propofol occurs. So whenever you are giving TIVA, always make sure that you have BIS monitoring, which is bispectral index monitoring. This will give depth of anesthesia. This will measure depth of anesthesia. Clear? Then there can be drug dilution errors. drug dilution errors, and also there can be malfunction of equipment. I hope this is clear. Now the last point for today. Let us remember the drugs that produce active metabolites. Drugs that produce active metabolites. Active metabolites. You can remember by the mnemonic ketamine, which will produce norketamine. Then we have thiopentone. Then we have midazolam, and also methohexital. These can produce active metabolites. So alright, this brings us to the end of the video. I hope you liked the video. Please click the like button, and if you haven't subscribed yet to the channel, please click on subscribe and click the bell icon to get all the notifications about the future videos. And please suggest these videos to your friends and colleagues, and do follow us on Instagram at our page Anesthesia Notes for more fun content and more entertaining educational content. Alright, so we'll meet in the next video. Until then, goodbye.